Good morning, and welcome to another edition of Medical Minutes. I'm your host and moderator, Dr. Peter Russotto. Today we welcome Dr. Jeff Olejnik. Dr. Olejnik is a board-certified obstetrician gynecologist affiliated with Passavant Physicians Association. Today's interesting subject will be prenatal care. Both Dr. Olejnik and I realize this is a very broad topic, and we hope to educate the listener to the point where they can have a good discussion with their obstetrician gynecologist. While I was doing a little research for this topic, I came upon an important statistic. Babies of mothers who do not get prenatal care are 3 times more likely to have a low birth weight and, unfortunately, 5 times more likely to die than those born to mothers who do get prenatal care. Medicine today has universally accepted the fact that prenatal care is important for the health and safety of both mother and baby. So, Dr. Olejnik, shouldn't any couple considering pregnancy see their doctor maybe even before they conceive?
Absolutely. With the unintended pregnancy rate as high as 40% and the baby's organs beginning to form as early as 17 days after fertilization, it's important for the mother's health to be in the best condition possible, and that she avoids certain medications, smoking, and alcohol. In fact, many people don't realize that you should already be on prenatal vitamins for a couple months prior to conception. Making sure you're on enough folic acid can help prevent such birth defects as spina bifida. Certain medical conditions, such as pulmonary hypertension, insulin-dependent diabetes, epilepsy, and thyroid disease, can greatly affect the outcomes of a pregnancy. It is important to discuss with your doctor such conditions as conceiving at an older age, history of a preterm birth or stillborn, any family history of genetic diseases or birth defects, and any occupational exposures to solvents or substances that may cause birth defects.
So basically, can you give us, or the listening audience, I should say, a generalized answer to what really is prenatal care in its simplest form?
Well, in its simplest form, in the beginning of the pregnancy, you should be seen every 4 weeks until 28 weeks, and then every 2 weeks until 36 weeks, and then weekly after that until delivery. Certain blood and urine tests will be performed at the beginning of the pregnancy, and then at the beginning of the 3rd trimester, the woman will be screened for diabetes and anemia. Ultrasounds are commonly performed at the first visit to ensure the pregnancy looks normal and that there's not a miscarriage or ectopic pregnancy. This ultrasound also confirms the pregnancy dating and the due date, as well as to determine how many babies there are. Another ultrasound is commonly performed at 20 weeks gestation to evaluate the anatomy of the baby and the location of the placenta. The gender of the baby is commonly determined at this ultrasound. Each visit with the doctor, the woman will have her weight and blood pressure checked, her belly will be measured in centimeters to follow the baby's growth, and the baby's heart rate will be auscultated with a Doppler. If any abnormality arises during these visits, then further investigations may be necessary. Let's talk about some more specific issues that usually takes more time to understand.
Well, during the initial encounter, though, also, I'm sure you get some past medical history for previous pregnancies, correct, in this prenatal visits, and then do you also get their comorbidities, like you discussed earlier, a little bit about insulin and everything? Isn't that important?
Yes. Any type of medical condition, we want to try and make sure that their blood pressure is under control, their diabetes are under control, and any medicines that they're taking, make sure that they're safe for the pregnancy, or if anything, to adjust their dosages.
Considering safety for pregnancies, there's always a big discussion about vaccines. Are vaccines safe for pregnant women? And if so, which ones should they consider getting while they're pregnant?
There are certainly a wide variety of vaccines that are out there, and some of them are unsafe for pregnancy. Again, at the preconceptional visit, looking at the patient's vaccination record, if the patient needs any vaccine boosters, they're best to be given even before she conceives. Some of the vaccines that I like to talk about is the MMR, or the measles, mumps, and rubella, the influenza vaccine, and the Tdap vaccine.
Could you elaborate a little bit on these actual vaccines?
With respect to the measles, mumps, and rubella vaccine, it's more important to get this vaccine, especially with the mumps outbreak here in Morgan County and the measles outbreak in Macomb. This vaccine is a weakened live vaccine that cannot be given during pregnancy, and if you can, it's best to get it preconceptionally. If you're found to be non-immune to this component, you have to avoid people who might have this infection and then wait until postpartum to receive the booster vaccine. Regarding the influenza vaccine, the season for influenza is October and March. Pregnant women may receive the injectable form of the influenza vaccine at any time during the pregnancy, but they cannot receive the nasal spray influenza vaccine. However, receiving the influenza vaccine cannot guarantee that you won't be infected with influenza. If a pregnant woman ever has any symptoms of influenza, such as a high fever and dry cough, regardless of their vaccination status, they should still call their doctor immediately to determine if this might be the influenza or some other bacterial or viral infection. If her symptoms are believed to be due to influenza, she can be prescribed an antiviral medication that can lessen the severity of the outbreak. Too many women suspect that they may only have a common cold and then wait too long to see if their symptoms get better on their own. By the time they actually call the doctor, it's too late to get the beneficial response from the antiviral medications. The last vaccine I like to talk about is the Tdap. This is the vaccine for tetanus, diphtheria, and pertussis. These three diseases are caused by bacteria that can cause muscle paralysis, respiratory problems, and even death. This particular formula of the vaccine came out in 2005, and the pertussis portion, or the whooping cough portion, is particularly important for pregnant women. Since 2004, an average annual rate of approximately 3,000 infant pertussis cases per year, with more than 19 deaths per year, have been reported in California and Washington state alone. Infants are not vaccinated against pertussis until 2 months of age. Infants who get infected with pertussis have a horrific coughing spells and may cause the baby to stop breathing intermittently, lead to pneumonia, brain infection, or death. The Tdap is an inactivated vaccine and is safe for pregnant women. One strategy is to have all the adults who might come in contact with the newborn get vaccinated before the birth of the baby. This creates a cocooning effect for the baby to limit possible exposures. If the pregnant mom receives the Tdap between 27 and 36 weeks gestation, some of these antibodies will actually pass to the baby, providing neonatal coverage until the baby gets its own vaccine.
Concerning the Tdap vaccine, shouldn't that be given with each pregnancy?
Yes, absolutely. For the pregnant woman, it is recommended that she get the vaccine with each pregnancy so that each baby can get the immunity from that vaccine. The other members in the family only need to get it once.
Historically, women really did not want to perform any genetic testing, not only because of the fear of finding out that the baby may have something wrong, but there also was a high number of false positive test results. Women, rightfully so, felt there was a lot of stress and anxiety waiting for the test results, and many times there was an abnormal screening result when actually the baby was completely normal. Women or couples were also hesitant to perform a diagnostic amniocentesis because the procedure itself had some inherent risks for losing the pregnancy. I believe since August 2012 there is a new genetic screening test that is both very safe and highly specific, something I'm sure excites you. Could you comment on this to our audience?
Certainly. First of all, the classic quadruple marker test that's been around for many years can still detect 80% of Down syndrome babies, but it does have a 5% false positive rate. This false positive rate a lot of times will make women more anxious when they have this happen to them. It also can detect 80 to 85% of spina bifida cases. However, there is a new cell-free fetal DNA test, also known as the Harmony test, that is much more accurate. It actually detects some of the baby's DNA that is circulating in the mom's blood. It can detect up to 99% of the Down syndrome babies with only a 0.1 false positive rate. This is actually amazing. The accuracy of this screening test is very similar to the accuracy of the diagnostic amniocentesis, but without the risks. This Harmony test does not screen for spina bifida, though. So if you want to be screened for spina bifida, you're more likely going to have to do the alpha-fetoprotein blood test and the ultrasound at 20 weeks. The Harmony test is still considered a screening test, and because it's still fairly new, it may or may not be covered by your insurance. The other huge benefit that this Harmony test has is that it can be done as early as 10 weeks gestation, where the old quadruple marker test has to be done after 15 weeks.
So in a sense, this new Harmony test was one of those what we would call highly sensitive and highly specific tests, correct?
Certainly.
Many women decline genetic birth defect screening because during their pregnancy they feel that there's nothing they can do if they have any abnormal test results. But hasn't technology changed or advanced to the point where something can be done for certain babies prior to their delivery?
It's amazing what can be done nowadays. In certain medical centers as Nashville, Tennessee, St. Louis, Chicago, and Peoria, prenatal surgery can be performed on the baby while the mother is still pregnant. Conditions such as spina bifida, twin-to-twin transfusion syndrome, and some amniotic band syndromes can be treated during the pregnancy. There are several other conditions that can be treated as well. And although these are high-risk surgeries, if the families meet the criteria, the outcomes for the babies can actually be better if the surgery is done during the pregnancy than after delivery. But even for a lot of women, just having the information and knowing that there's a problem can better prepare the family for an inevitable delivery that the baby might have a problem. Sometimes a condition diagnosed prenatally may actually dictate the woman to deliver at a higher nursery hospital that's more suitable for caring for such a problem. If the baby is diagnosed with a lethal condition and that would otherwise not survive, we can have a discussion with the mom in order to make plans for such a condition.
Isn't it true that about 10% of all babies are still born premature, and preterm birth puts babies at risk for immediate and long-term problems? Can you tell me some of the points of contact with your patients that may decrease preterm birth?
Sure. And again, it comes back to preconceptional counseling to help the patient stop smoking, following a balanced diet, and screen for certain medical problems or infections in order to help decrease the risk for premature labor. Early prenatal care and educating patients about the warning signs for preterm labor can help too. Women experiencing preterm labor can be treated with antibiotics that prevent infections. Steroids can help the baby's lungs work sooner and prevent bleeds in the brain. And magnesium sulfate now to help preserve brain function. For women who have had a previous preterm birth, treating them with progesterone supplementation during the pregnancy may show as much as a 40% reduction in a preterm birth. Currently, at-risk women are treated with weekly injections of progesterone between 16 weeks and 36 weeks of their pregnancy. And now it's been shown that daily vaginal progesterone suppositories may have a similar benefit. Again, this all emphasizes the importance of early prenatal care to prevent these problems.
Pregnant women are always concerned about certain risks or possible complications during transportation, such as travel with a car or an airplane. Can you elaborate what are the real risks to a pregnant woman?
Sure. The stereotypical scenario is when a patient asks me if they can travel because they have this fear of going into labor or having their bag of water rupture in the airplane. But actually, travel in a properly pressurized aircraft offers no unusual risks, when in fact, the real risk with pregnant women traveling is developing a blood clot in their blood vessels in their leg in the form of a deep vein thrombosis, which in turn can break off and become a fatal pulmonary embolism. The risk for venous thromboembolism has been estimated to be 5 times higher in women who are pregnant than women who are not pregnant, and it is recommended when you're traveling to make sure you're wiggling your legs in the car or airplane or get up and walk around at least every hour or two, and then use the seat belts as appropriate. I also always tell my patients to bring a copy of their prenatal records with them just in case they end up in a prompt care center or an emergency room during their trip. This helps them get through the emergency room faster, making sure that the doctor there has all their information with them.
You briefly talked about DVT, deep vein thrombosis. A lot of times in other adult populations, I know I tell my patients when they're traveling or going to be sitting in a long period of time to maybe take an aspirin before they travel. Is that recommended for a pregnant lady?
We use aspirin sometimes for patients to help prevent preeclampsia or for other conditions. But for traveling, that's not something I usually recommend for such a short-term basis.
So it's something that they shouldn't do on their own. They should only discuss that with their OB-GYN, correct?
Sure.
Very great information, Dr. Olejnik. We thank you for coming. Dr. Olejnik and I thank you, the listeners, for joining